Good afternoon, everyone. So welcome today to the session, Nothing About Us Without Us, Advancing Human Rights for Key Populations. And we're very fortunate today to have a high-level address by Lisa Maria Singh. Lisa is a senator from Australia representing the state of Tasmania, and she belongs to the opposition the Australian Labor Party. She was first elected to the Australia Parliament in 2010, and since that time she's had a strong focus on human rights, international development and the environment. Senator Singh is co-chair of the Australian Parliamentary Friendship Group for HIV/AIDS, and also co-chairs the Parliament's UNICEF Group and Australia TB Caucus. Lisa has worked closely with the Global Fund, advocating for Australian government replenishments and greater support for HIV, TB and malaria in the Asia-Pacific region. In 2016, Lisa represented Australia at the United Nations General Assembly in New York, participating in resolutions and statements on refugees, the Sustainable Development Goals and women's empowerment. Thank you.
Thank you very much. It's an honour to be here today in Amsterdam at this International AIDS Conference for 2018 and to share with you some of Australia's experience of the AIDS epidemic and to reaffirm our commitment to human rights as the touchstone for its prevention and treatment. Australia's progress towards the elimination of AIDS demonstrates that human rights, human lives and human experiences are central to the global battle against this disease. Today's session, Nothing About Us Without Us, is aptly named. Policymakers cannot work to eliminate AIDS without recognising and prioritising the human reality of those it affects. The fight against AIDS has been interwoven throughout history with movements towards the recognition and promotion of human rights. Across the world, communities which HIV has hit the hardest are all too often victims of a myriad of other forms of discrimination. Indeed, Australia's first AIDS diagnosis in 1982 came at a time when homosexual sex was still a criminal activity in more than half of the country. Already marginalised and isolated, we know that communities impacted by AIDS can easily be further discriminated against, locked out of the policy process and denied access to adequate medical care. Too frequently, this has been the reality. Prevention and treatment have been sidetracked by stigma, leaving the most vulnerable behind. In Australia, however, a combination of determined activism and progressive fact-based policy making has meant that the human individuals most deeply impacted by this epidemic have consistently been central to the fight against it. As infection rates began to increase in the early 1980s, the federal government committed to a range of preventative policies driven by the principle of harm minimisation and informed by consultation with affected communities. Many of these measures seemed radical at the time, but they have proven to be crucial tools in preventing the spread of AIDS and improving the lives of those living with HIV. Firstly, and most importantly, governments at every level in Australia dedicated themselves to real engagement with bodies representing the individuals directly impacted by AIDS. Advocates of the LGBTIQ community, for sex workers and for intravenous drug users became part of the policy conversation, and the establishment of the Parliamentary Liaison Group for HIV and AIDS created space in the corridors of power for ongoing discussion with affected communities. These conversations led to policies directly informed by the lived reality of those they were designed to protect. Anonymous, free HIV testing was made universally available. The implementation of needle exchanges and methadone maintenance treatments subsidised by government helped prevent infection amongst intravenous drug users. Education and awareness campaigns were informed by facts and able to speak directly to those at the highest risk. The history of AIDS prevention and treatment in Australia has been underwritten too by our firm commitment to universal high-quality healthcare. For Australian AIDS diagnosis came just 2 years before the introduction of a universally accessible, publicly funded medical insurance scheme which allowed for subsidised access to crucial treatment. And now, just a few months ago, HIV pre-exposure prophylaxis, known as PrEP, was listed on our National Pharmaceutical Benefits Scheme. With a simple prescription from a general practitioner, an Australian at risk of infection now has cheap and easy access to this potentially life-saving treatment. Nevertheless, despite these advances in Australia, work remains to be done. In Australia and indeed throughout the world, the most vulnerable communities continue to be disproportionately impacted by HIV. Aboriginal and Torres Strait Islander Australians are diagnosed with new HIV infections at a rate more than double that of non-Indigenous Australians. And that rate has increased over the last 5 years as the rate of infection amongst non-Indigenous Australians has declined. Refugee and asylum seekers, transgender people, individuals who are incarcerated or experiencing homelessness all struggle to access diagnosis and treatment which are crucial to successful management of this disease. But recognition and promotion of human rights has a crucial role to play in this fight against AIDS, both in Australia and across the Asia-Pacific. Ongoing discrimination against the communities most vulnerable to infection renders the implementation of education and preventative measures next to impossible. Discussion of safe sex cannot take place when public identification as a member of the LGBTIQ community could lead to your arrest. Treatment for HIV is not an option when outreach work is criminalised and those who deliver it are subjected to campaigns of intimidation. So it is our responsibility as an international community to do something about this, an acknowledgement of fundamental human rights, that health is a basic human right to which all human beings are entitled without discrimination, and recognition that no health issue can be adequately prevented or treated while those rights are denied, must underpin our efforts to combat the spread of HIV. So together, I hope that we can work to ensure that every individual, every human life, has access to the support and care they need to live with freedom and dignity. Thank you for inviting me here today.
Thank you very much, Senator Lisa Singh, for your very insightful address. Good afternoon, friends and colleagues. My name is Monica Beg. I'm the Chief of the HIV Section and the Global Coordinator for HIV/AIDS at UNODC. I am your co-chair, and I will be co-chairing with this session with Judy Chang, who is the Executive Director of International Network of People Using Drugs. Thank you very much for joining us here today in this very important session. Nothing about us without us, advancing human rights for key populations. Nothing About Us Without Us is a manifesto which was adopted by people who use drugs in 2008, and since then it has been critical in ensuring engagement of people who use drugs and other key populations in the AIDS response. We all know that the Global Agenda for Sustainable Development includes a target of ending AIDS epidemic by 2030. To be on track in meeting this target, the world must achieve several interim milestones, such as 75% reduction of new HIV infections or less than 500,000 new infections by 2020. The good news is In 2017, globally, the number of new HIV infections continued to decline. The not so good news is the progress is far slower than what is required to reach the 75% reduction by 2020. And the bad news is, while the world continues slowly to the path towards ending the AIDS epidemic, national epidemics are increasingly being concentrated among key populations. Globally, in 2007, 47% of all new HIV infections were among key populations and their sexual partners. This percentage varies by region. For example, more than 95% new infections in the Eastern Europe and Central Asia region and MENA region were among key populations. It also varies by key populations. For example, almost 60% of new HIV infections were among gay men and other men who have sex with men in Western and Central Europe and North America. More than 1/3 new infections in the Eastern Europe and Central Asia and MENA region were among people who inject drugs. 1 in 10 new infections were in Eastern Europe and Central Asia and in the MENA region were among sex workers. The question is why? The last 3 decades of the AIDS pandemic have also seen an epidemic of international commitments, political declarations, frameworks, evidence for action, tools, and guidelines. Then why the key populations are still disproportionately affected? We all know the answer. It is mainly due to pervasive and widespread human rights barriers, including stigma, discrimination, violence, and other abuses, as well as legal and policy obstacles and related practices. These not only contributed to their vulnerability to HIV, they also limited their access to evidence-based prevention, treatment, and care services. Today, we have a panel of distinguished speakers who will address all these issues and will also discuss the new strategies which communities are applying in regions with shrinking spaces for civil society activism. Judy.
So I'm very pleased to be introducing our first speaker, Vitaly Juma. He's the Executive Director of the Eurasian Coalition on Male Health. Vitaly has been involved in the response to HIV for over 15 years with a focus on the most affected populations in Eastern Europe and Central Asia. He's a staunch HIV and human rights advocate for the community of men who have sex with men in the ECA region and an important voice given the ever-shrinking civil society space.
Thank you, Judy. Thank you, Monica. Good afternoon, friends. Actually, this year it's 20 years since I started my professional careers in the HIV field, but I never considered myself fully professional. I am an HIV activist at heart, and from the beginning, I was involved in the HIV response in Eastern Europe with different key populations, first in harm reduction with people who use drugs, and since last 5 to 10 years with my own community of gay and bisexual men. And this community is the one that I will be talking about today. My organization is a regional association of LGBT organizations, activists, and allies working on HIV among gay and bisexual men and other men who have sex with men, as well in trans people in Eastern Europe and Central Asia. We are a relatively new association. We got established back in 2011. And prior to that, in 2010, we, LGBTI and HIV activists, UN agencies in the region, some governmental allies, met for a regional consultation to discuss the situation. And we named that consultation back then Hidden Epidemic of HIV among MSM. But hidden epidemic was for us always in quotes, because we knew it was not hidden. Although official data only supported this thesis of high HIV epidemic in 2 countries back then, 8 years ago now, we continued ringing alarm bells, although to no avail. And now we have a full-blown HIV epidemic among my community in most countries of the bigger region of Eastern Europe and Central Asia, as well as Southeastern Europe. There is the HIV prevalence among my community has already exceeded the so-called concentrated stage of epidemic. And in a country of Georgia, the HIV prevalence rate among gay men and other men who have sex with men is already 20%. So in addition to the full-blown epidemic among people who use drugs in our region, we have already the second full-blown epidemic among my own community. The response to the situation is bleak, and the HIV treatment cascade is a clear example to it. ECOM, my organization, Eurasian Coalition on Mental Health, ECOM, we just finished a study on HIV treatment cascade for MSM in several countries. 4 of those countries, the data for 4 of countries I used here from our study, and the data for Russia is from another study, but the data is clear. Only 4.6% of HIV-positive gay men in Belarus have access to treatment. Only 11% in Macedonia, only 7% in Kyrgyzstan. So why is it? Living next door to West Europe, where already there is a talk about reaching 1990, there is already talk about what to do with those 10% who are left behind. Why is the situation so bleak? Let's look briefly at the legal environment in terms of, in relation to LGBT issues. Being next door to European Union is actually helpful to some of us, and it means that the bigger region of Eastern Europe and Central Asia is divided in 2 parts. So one of the parts of our region is clearly aligned with the European Union, EU. Some of the countries in the region are EU member states. So we have anti-discrimination legislation in place, although no constitution in those countries specifically mentions sexual orientation and gender identity as a cause for anti-discrimination action, but we can use those mechanisms that already are in place. Although, if you look east, the situation is the same old Soviet-style dichotomy, east-west. The country to the west to the east of the region don't want to change anything. Same-sex relations are still criminalized in 2 countries. They never thought of repealing the Soviet-style legislations, anti-sodomy legislation. As you might know, and as we perfectly know, Russia reintroduced de facto criminalization of homosexuality, calling it gay propaganda ban. And the similar attempts were registered in many other countries throughout the region. Go east or go west in our region, we also have some repressive legislation. In several countries prohibit us, gay and bisexual and other MSM, from donating blood. Criminalization of HIV transmission is present in 14 countries. And as you can see, Belarus initiated prosecution of 100 people last year based on the HIV transmission or HIV exposure indictment. Rights violation of LGBT people are rampant in the region. We experience domestic violence. We experience public attacks on us as well as on our events. we experience state-induced violence, and this domestic public violence and state violence has clearly manifested in the situation last year in Chechnya, where families and local authorities were hunting and killing us while federal authorities of Russia were trying to hide the crimes. This situation is far from over. Only last week we learned that a young gay refugee from Chechnya in St. Petersburg in Russia, he fled his own family, his own home, but he was kidnapped. And only thanks to the involvement or interference of LGBT and other human rights defenders in the city, we were able to took the guy, the young, almost boy, the young guy back from his family. Being the organization that works on health issues, on health and HIV issues, and gay and bisexual men as well as trans people, we clearly see rampant or widespread violation of our right to health care. There are multiple examples of refusal of services based on sexual orientation and gender identity. The most spread violation of our right to health is breach and confidentiality of our health status or behavior, of HIV status or sexuality. And this leads to major implication, as you can imagine, in the situation of the rampant homo and transphobia. And we even have reported cases of blackmailing by healthcare workers. So while legal environment in the region differs between so-called West and so-called East, the day-to-day reality is similar around the region of Eastern Europe or sub-region of Eastern Europe and Central Asia, be it in accession country, in EU accession country in Macedonia, or in EU member country Latvia, or in Russia. Our rights are violated daily by by society and by the state. This is a map regularly prepared by International Lesbian and Gay Association in Europe that we as a common member of. This rampant homophobia, rampant violation of rights, of our rights, also influences our own self-esteem. ECOM, Eurasian Coalition on Male Health, just finished a unique study on internalized homonegativity, where we made the hypothesis that negative attitude to own homosexuality is increased in homophobic society. It was a rather big study with more than 8,000 respondents. Most respondents luckily accept own homosexuality. However, we should notice that the respondents are online users. We received a big help from our partners at Hornet and other social media. So, of course, people who use those applications are more advanced in their own acceptance. So we can assume that the internalized homonegativity or homophobia is much higher in general gay men's population. But this is not the most interesting, of course, result. Our study clearly showed associations, direct associations between use or between higher use of HIV services and lower internalized homonegativity. For example, as you might see, you can see, I think so, yeah? As you might see, people with a lower level of self-acceptance, never received or didn't want to receive free condoms, and those with higher acceptance of sexuality, of homosexuality, received the condoms. And this data consistently showed us the direct link or direct association between lower internalized homonegativity and higher use of HIV services across the line. And so one of the biggest conclusion of our study is that the greater acceptance of our own homosexuality is associated with more regular use of HIV testing and prevention services. What do we do to counteract human rights violation, widespread human rights violation in the region? ICOM being an advocacy association in the region, we help our partner and member organization raise awareness of our counterparts in official structures, in healthcare and social care, by providing trainings. We regularly monitor and document cases of human rights violation. Again, being an association focused on health, we mainly focus on discrimination and human rights violation in healthcare settings. Last year, we documented 35 cases that were or will be used for reports to UN treaty bodies, to shadow reports to UPRs, and so on. We provide safety and protection in emergency situation to our members and partners by supporting, for example, an innovative, in our region, small emergency response group in Kyrgyzstan, LGBT emergency response group. And we also provide personal protection of LGBT health activists in dangers. Right now, we help to relocate an activist from one country to another in the region. So, but he was able to come here, luckily. And using the results of our study, or based on the results of our study, we try to increase awareness of our own community on the issues of interest to our lives and our health and our lives. So we provide trainings, we provide grants for community mobilization, not only small grants, but rather bigger grants. And one of the example case study is a Gender Z. It's a young organization in city of Zaporizhia in Ukraine, in the center of Ukraine. Was it center or southeast of Ukraine? And our partners is here. So we provided a rather small grant to the organization to do a project on stigma and discrimination. It was called a secret client. So young boys from the organization or young guys from the organization went to 92 institutions to receive HIV testing. Poor guys, some of them experience up to 20 punctures to get their own blood test. So many cases of violation of access to healthcare were identified. The organization prepared a report and discussed it with the local health administration, and they already are discussing changing the local or provincial standards of services, of testing services. Recommendation, I would like to finish my presentation with recommendation. I will not go through all the recommendation to our own community. However we frame the discourse, being it decreasing internal homophobia, being it community empowerment, It's all about us. Nothing about us without us is not possible if we don't cherish our own dignity, if we don't accept our own sexuality, if we don't accept our own human rights. This is the very first recommendation. And the second recommendation to the community of LGBT people is build coalitions, build strong coalitions with other communities. We already do it on regional level, but also on country and local levels. My organization is working closely with Harm Reduction Association, with sex workers advocacy networks in the region, with regional union of people living with HIV. The same is done at the regional level, and one of the results of this cross-community cooperation is the advocacy campaign that we are conducting here within this conference. I will not go into all the recommendations for decision makers. The only one message to decision makers is clear: chase the virus, not people. Thank you so much.
Thank you very much, Vitali, for your excellent presentation. Our next speaker is Lynette Mabote. Lynette is the Regional Program Lead at the AIDS and Rights Alliance for Southern Africa. Lynette has worked on numerous projects and programs in public health. She is currently representing ARASA at the African Commission for Human and People's Rights. Lynette has extensive experience in HIV and TB, public health and funding policy issues within Southern Africa and broader Sub-Saharan Africa. Lynette, the floor is yours.
Thank you, everyone. Can everybody hear me? I know it's been such a long day. Hey. Oh, this conference. So that's what happens when you're a human being and you're surrounded by many human beings. The energy makes you high, and then it gets to you that you feel like a baby because all you want to do is cry at the end of the day. I'll try to be snappy, I'll try to be quick, and I'll also try to be as fun as I can, although this is not a fun topic at all. I do definitely agree with my brother that, we need to chase the virus and not the people. And the impact of chasing the people and not the virus is really starting to show. And I think we need to make a plan to move forward this discourse. So my organization is the AIDS and Rights Alliance for Southern Africa. We are a partnership of 113 civil society organizations that are formed actually within various makes and sizes across 18 countries in Southern and East Africa. So when we think of the definition of what detention is, and it's not necessarily just prisons, right? Places of detention are places where people's liberty are literally cut short, right? There are places where people's virtues are minimized. It's a place where people's dignity are literally at the mercy of other people. So OPCAT under Article 4.1 refers to it as detention being any place under its jurisdiction and control where persons are or may be deprived of their liberty either by virtue of an order given by the public authority or at its instigation or with the consequent with its consent or acquiescence. So within where we come from, I think what the story that we are trying to tell is a very simple story. The justice system is simply failing people. And these people are people like us sitting in this room, are our brothers, our sisters. How many of you have family members who are incarcerated or are in a place of detention? How many of you in the room? Okay, I guess I'm the only one. Okay. Well, in my region, there's a lot of us. Generally, at a conference of this nature in South Africa or anywhere in SADC, it's more than half the room. And that is because of, I think, the type of environment in which we live. So the reason why I'm showing a few of these articles is just basically to show how low it goes, where people are arrested literally for stealing a chicken, for stealing a piece of bread, and this 13-year-old girl was literally incarcerated because she stole something. And because she was hungry, it's not necessarily because she was trying to be a criminal or to be a bad person, or she was basically not even put in juvenile court. So we are saying that the judiciary is failing, and we are literally creating a public health catastrophe in a lot of our jails. A lot of our prison cells are over max capacity at current point, with WHO and UNDC seeing the prevalence rate being from 6 to 50 times higher within African prisons than the rest of the world. And we are seeing increasing numbers of tuberculosis. We are calling prisons now in our region the breeding ground of multi-drug resistant tuberculosis, seeing cases in prisons rising up to 24%. One can try to give two arguments to this, right? So we do a lot of human rights work at ARASA, and the human rights argument would say that everyone deserves human rights, everyone deserves dignity and respect and so forth. We are told, well, these are criminals, they deserve to be locked away. And we say, okay, but there is a very strong public health argument to this. Where do you think everybody goes when they leave the prisons? Not the prisoners, right? We're talking about the wardens. We're talking about people who work in the prison system. Where do they go? They basically go back to communities, and that is what we're saying. We are creating a breeding ground of tuberculosis. I wanted to also just take a moment to look at the vulnerable groups that we're facing in the detention settings. This is something that is increasing, and it's something that we really need to start doing a lot of research around. There's not a lot of research that's done in this area. So when you're looking at the vulnerable groups in detention areas, we're looking at some of these groups here being women, children, and I just wanted to highlight the ones in red for in order to save time. We're looking at people living with HIV, refugees, economic migrants, asylum seekers. We're looking at sexual minorities and transgender persons. We're looking at sex workers, as well as victims of long life sexual, domestic, and state-sanctioned violence. So we're looking at everyone, really, literally. And if you're looking at women as a vulnerable group, we don't have a lot of data that tells us what the situation looks like. I mean, unless you're in a country where you've got a penitentiary system that separates the so-called sexes, you are looking at very weak data. And within the African setting, we really are struggling. So, for instance, data that we have from the 27 World Prison Population List, the figures basically are saying that we've had a 20% increase of women in prisons since 2000. So basically, this increase, if you're looking at within the same period, is within men, we had 18% increase since 2000, and in women, a staggering 15% within the same period. We are seeing a lot of women and girls being incarcerated. Within South Africa, the numbers are also not looking that great, because of the 161 offenders, we're looking at about a very high prevalence, 4% prevalence being women, and we're seeing that this number is increasing on an annual basis. The two crimes that the research is seeing, and this research that was done by the University of Cape Town, it was produced by Dr. Lillian Arts, is looking at women who are generally incarcerated for economically related concerns, and you're also looking at those who are said to have perpetrated aggressive crimes. We don't have official data because data is not disaggregated in our prison system, unfortunately. So what are some of the response mechanisms that we've come up with as civil society within Southern and East Africa? So I think besides trying to engage our governments as well as our regional bodies to reform or to change the prison system, we've seen a lot of great case studies coming out of civil society work that's been done on the ground. So this is work that our partners, the Center for Human Rights Education, Advice and Assistance, who are actually at this conference, CREA, did based in Malawi. And they're working very closely with the Southern African Litigation Center as well as within MSF. One of the areas that they focused on was how do we increase resource allocations to the prison system. And this was basically looking at a reform model which looked at strengthening the prison system so that we could offer services to inmates. And with the advocacy that they did, they were able to actually increase the minister's the annual budget allocation towards towards the prison system within the years 2016, 2017. This work continues in the country because, I mean, this actually presented a 60% increase within the prison's health budget within the 5 years that preceded 2016 to 2017. Civil society have also started being represented or being representatives of important structures, such as our colleagues in Malawi, who are now part of the Judicial Core Group, which is very important. The case study of work that's been happening in Uganda is our partners, UGANET, are doing a lot of work to increase the capacity of women in prison to be legal service providers. So this increases access to legal aid and ensures that people are starting to be aware of their rights, and it gets the women involved in other matters in order for them to actually move forward some of their cases. So far, 20 women have been trained, and it seems like a very good program that we really want to scale up as a human rights intervention, because we think that is one of the easiest ways that we can try to reform a prison system from inwards looking outwards within our region. When we're looking at who exactly is criminalized, we're seeing increasing cases of even people living with TB being criminalized for lack of adhering to their medication. This was a case that was done by our partners in Kenya, Kellen, who basically took government to court for incarcerating these 3 gentlemen for not adhering to their TB treatment. I wanted to just read something, or just look at something that was investigated by Commissioner Kagwa, who's the Special Rapporteur on Prisons at the African Commission for Human and People's Rights. In 2012, he already said that, we're already facing a prison population that's risen by 71% since 2009. This is in 2012, by the way. And the prison population has increased to such an extent, around 50% of prisoners are on remand, possibly for crimes as minor as stealing a pen or a chicken. Right? With government's claims that reform and rehabilitation as the aims of the criminal justice system, in practice, prisons fail to deliver as expected, and recent reports have shown that the prison system in Africa and African countries are in crisis, right? We're facing overcrowding and inability to satisfy basic human rights standards, and as much as they have ratified a lot of regional and domestic protocols and conventions, the situation is unfortunately getting worse. So we have come together as a global movement of civil society to try and address one thing that we're really seeing as rampant. At current point, we have 73 countries around the world who are criminalizing HIV exposure or perceived or actual exposure, non-transmission, as well as non-disclosure. With the work that we're doing under the HIV Justice Worldwide, we are starting to look at an area which we are really getting nervous about, because there are quite a large number of persecutions against people living with HIV. While you can't see properly, these maps show you exactly countries which either have specific HIV laws, which do criminalize you for having HIV and not necessarily disclosing to your partner, as well as countries which are using the criminal law to aggravate, to have aggravated sentences based on HIV status. So if you're positive, literally for performing an act or omitting to perform an act, you can be incarcerated for a long period of time. As we've seen in the United States, people have even been incarcerated for spitting on a police officer. We're hoping that through this work, we'll actually be able to end HIV criminalization and start reducing the number of persecutions that we are seeing increasing around the world. I mean, right now, we are facing a really desperate situation with our prison system. And as I said, there are 2 arguments to give. There's a human rights one, and if that doesn't work, we really have a public health one. So if we are incarcerating people living with HIV and we're incarcerating people who are affected by tuberculosis in the prisons, number 1, with tuberculosis, we are creating factories in the prisons. Number 2, with HIV, we are just increasing the prison numbers, and our prisons are beyond capacity. As our deceased hero Nelson Mandela said, it is said that no one truly knows a nation until one has been inside its jails. A nation should not be judged by how it treats its highest citizens, but its lowest ones. So I encourage you all to really also engage with something that was launched today. Today we released a scientific opposition paper that is pulled together by 20 globally recognized scientists that looks at the area of viral load. Because a lot of us in our jurisdictions, when we're facing the criminal justice system with the HIV cases, we're told that there was transmission, even though we do not have either genotype testing or we don't have forensic testing. So we're hoping to use this statement to basically influence policy and to basically say that if people adhere to their treatment, if people get viral load, consistent viral load, people will be undetectable. So we really need to start promoting that narrative to reduce the numbers of criminalization cases that we're seeing in the region. Thank you.
Thank you very much, Lynette, for shining a spotlight on the injustice of the judiciary system and the severe public health and social costs of criminalisation. So next, we have Alexei Kermanevsky from the Eurasian Network of People Who Use Drugs. Alexei has been a vocal activist for the community of people who use drugs in Russia for many years. He started working in 1999 as an outreach worker and progressed to working as a coordinator, is now trained as a human rights lawyer and is a co-founder of Drug User News.
Thank you very much, Judy, for introduction. Good day, everyone. Good evening. It's very happy to be here again and to stand and thinking and listening for so good people and so terrible stories. Even for today, I usually thinking about what happens with our world, what's going right and what's going wrong, why we live in such time when there's such high level of progress and such terrible things happens with humans. When I was 15, I live in Russia, in Kazan. When I was 15, I faced with drugs. When I was 16, I go to a doctor, the first time in my life. I wasn't a crime. I do not do some crime things. I live a normal life with normal family. And I came to normal hospital. And it was my first time when I meet with serious disease with doctor. What I get after a few hours, I was lying in the bed with ropes on my legs and my arms. And they said, do you need to stay here for 3 days when your withdrawal will go on? It was a very strange feeling, and I can't remember what I feel right now, in that moment there, because I'm not thinking about my pain. I'm just thinking about why it happens with me, because I do nothing strange, nothing bad to this world to get such kind of relationship from the doctor. After I finish this first detoxification, I go out and I don't know what to do because my school was not so good results. My education in the school was not so good because last several months I using drugs and I don't get time for my education. So I decided to continue to live as I'm living, but I have harm reduction friends because, it's another. And it's a little bit late, I've met with first a woman who have idea to make a harm reduction program in my city. Her name was Larissa Ivanovna Badrieva. It was the idea to save our city, our country from AIDS, because epidemic is starting and I don't know nothing about it. And she just invited me to work like an outreach worker. And since that moment, I've seen a lot of people from this day which are coming on my outreach work. And I realized that they all live in such conditions that they need to hide themselves from everyone. I realized that my right for freedom also was break, because if somebody knows that I'm using drugs, it's opened the opportunity for me to get into prison for different reasons, for selling things from shops, for using drugs, etc. So all of those people who come into me like clients do not have access for prevention of the diseases because they're scared to go to drugstores, they're scared to go to doctors, they don't have time for education and don't get chance for a normal life. But many of them have families, and I saw the stories when mother and father go wasting out of this house his child because they was addicted on drugs, and they don't want to see them. Almost the same situation has happened with me. My parents was divorced because they can't help me, and mother can stay with me, and father decided to live a normal life without this problem. This is I realized a little bit later, maybe 20 years after. Sorry. So, and when I continue to work in harm reduction program, I see that if nothing gonna be changed, if I don't show the people the idea of this system and idea that we need to protect ourselves from this violation, nothing gonna be changed. But and this was one of the meeting of harm reduction organizations, and one person said that you will change the situation if somebody just alone stand and said that I need to change it. No one else can come and change something in your life. And I realized that it's just me, the person who can change the life, not only my life, but life of my clients, life of people in my city. I need to share. It was very important to make an example, make a first step, and show the people that they can change something. I know about substitution treatment a little bit after I continue working harm reduction. I get a new knowledge, and I know that I get the information that different countries are using substitution treatment for treating drug dependency, but not in Russia. It was prohibited. So, and I find a lot of information and find the one doctor in my city who said, yes, you need this treatment and it can help you. So after this, I decided to go through this way and trying to write a first applicant to my doctor, complain to my doctor that I need to get this treatment because other things didn't help me. I get first response that unfortunately in our country it's prohibited. But the most important for me in that situation was to realize that all system, I mean medical system, law system is based on things that thing that breaks my right of human. And I decided to go further. The next step was first court in my city, because if I want to finish this case, I need to go through every step by step through all system of court in our country. So, and it takes maybe 3 years when I going through this process. And all this time, police, I know there are 3 guys who I know from the drug department. They usually come to me and tell me that soon you will go into a jail. Soon you will go into a jail. We are very, very believe that soon somebody catch you with 5 grams of heroin in your pocket and you will go to a jail. Stop doing what you're doing. This action of going to the court, because my complaint now in 2010 was sent to European Court of Human Rights, and after this moment it gives people chance to open their mouths and to talk about their stories. Since that moment I realized that I need to help people, like a person who know well about the laws and who can be in the court, who can represent the stories and cases of people who use drugs. I go to finish to university and begin working with the Forum of Drug Users of Russia and helping to document in cases and helping people with courts. Now this mechanism, I mean Forum of Drug Users, work without any funding and helping every day tens and thousands of people. These actions, firstly, when my case come into mass media sources, it's make like a really earthquake in my city, in my country. The big mass media, but it's funny that the announcement was very exciting. For example, HIV positive drug user go to European court. What you can think about if your name will be like this in some of new newspapers, that you are HIV positive drug user, go to European court. I can't show this paper to my sons and said, look, this is your father. I don't think that it's a good thing for proud of. 1 year ago, I leave Russia and now I'm living in Israel, because all this time I still have problems with drugs. I get the remission for some period of time, but the longest period of free from drugs was something like 2 years maybe. And in Russia I was 23 times in detoxifications and going through rehabilitation center. And now I leave this country. Now I live in Israel. 1 year and 2 months I get access for for treatment that help me. I stand on this program of substitution treatment by Suboxone. In Israel I get a citizenship because my wife get a chance to go to this country and because she's a Jewish. And so the first meeting with, when I came to Israel, I'm also take my fear with me, because when I was there, I know that that there is access for, I can get access for substitution here, but I was afraid to go to the doctor. I was 37 years old. The man with 2 sons, with wife, who afraid to go to the doctor. But I step through this afraid and go to a clinic, go to site. I meet with the doctor Victoria. She's a Russian. She worked 15 years in Israel. And when she look at me, she asked, Russia still continue to ban opioid substitution treatment? I said, yes. Why are they doing it? 5 years ago, they come and we saw a lot of doctors. We showed them everything. They knew that it's effective things. And I said, I don't know. Today, if you look at the life of the people who use drugs, you see that they don't have normal rights. Everybody here in this hall, I think most of you, have your normal life. You can choose the way of life, you can choose your job, you can choose your family, you can choose your hobby. But it's a little bit difference between me, because when I get the wish in my heart or in my brain, the first thing that I'm thinking about, do I have the right for it? Because I'm a drug user. Maybe there is some barriers, maybe there is some criteria. Every time when I get into some big office or big mall, I'm scared. I'm putting my eyes down, because I think maybe they would some think that I couldn't stand here and I couldn't be here because of HIV positive people. Even when I coming home, today is 10 years date when I get married with my wife. It's every time happening that when we get this date, I'm going somewhere to some conference or something. It's very sad for her. And she knows me for 10 years, and I don't know what's wrong with this woman, but she's still with me, really. And in October, we gave birth for my third child. And you know that human rights, it's very hard for me to talk because I'm so tired to talk about such formal things. I know that there is very a lot of NGOs and different agencies who are trying to solve this problem. Solve the problem on respect between people, solve the problem of living without love for human beings. And I don't know what needs to be happens with our world to stop epidemic and to stop the violence against the people and stop violence, stop the epidemic and violence between the husband and his wife. I think that we need to love each other more, try to look at each other and see the man, see the human. Thank you.
Thank you very much, Alexei, for sharing your personal story with us. Very, very powerful, and I really admire and respect you for your bravery and resilience. Our next speaker is Dottie Oguto and Koli Sisonke. Dottie Oguto is the Executive Director of African Sex Workers Alliance. She is a founder of ASWA and a pioneer of the sex workers movement in Africa. She is also the winner of the Society for AIDS in Africa Leadership Excellence Award, ICASA 2017, for her outstanding contribution towards the AIDS response in Africa. Dottie also serves on numerous committees and governing bodies representing sex workers and key populations in Africa and globally. And Koli is the national coordinator of Sisonke, the national sex worker-led movement in South Africa. She is also a member of the Sex Worker Education and Advocacy Task Force Management Team. Koli is an active advocate for sex workers' rights in South Africa and at the regional and international levels. She also sits on the Global Fund CCM in South Africa as an alternate member.
Thank you. So I will speak about a regional perspective and give practical examples as to how the African sex workers movement is challenging criminalization of sex work and really fighting for the decriminalization of sex work in across Africa countries. And I will highlight 3 particular examples, but then Koli will give us what is our ideal scenario, our ideal, Africa borrows a whole bunch of things from South Africa, and therefore we are counting on the South African sex workers movement to actually be the first African country to decriminalize sex work in Africa. And soon after, other countries will follow suit. Just a brief overview about ASWA and the Africa Sex Worker Alliance is that we are a regional movement of sex worker-led organizations and groups across 34 African countries. And these, the sex worker-led groups and organizations primarily have emerged out of a context of pushing back on the punitive laws against sex workers in Africa and looking at how can we have better legal working environments that support, sex worker rights and ensure that sex worker needs, in particularly health and human rights needs, are being met. The background of our organization is that we clearly came out as African sex workers in 2009. That's 9 years ago. To call for a decriminalization of sex work, to actually call out the human rights violations and name the perpetrators of the human rights violations against sex workers, who were mainly the police, and so those are state actors, but even our clients who were being left scot-free simply because of the criminality of sex work. Some of our best practices actually come from 3 countries, and one of them is Senegal. Senegal is the only country in Africa that legalizes sex work. However, it is an ideal scenario because it is an environment where it's a francophone country, so it was colonized by the French, and therefore the laws in Senegal are borrowed from France. And sex work is legalized in Senegal, whereby the sex workers find it a favorable working environment. It is not ideal. It is not the idealistic one that the sex worker communities would have. However, it is one that they are able to work and operate in. The however comes in the case where the state has imposed mandatory tests and screenings of sex workers. And if you give a positive test for any STIs or HIV, then you're publicly named and shamed. And that's a human rights violation. However, sex workers in Senegal are able to work, but still work within the confinements and the provisions that are given by the state. Our next ideal case and case study is from Kenya, where we have seen actively Kenyan sex workers who are engaging with lawmakers, with policymakers, in trying to repeal the penal code of Kenya, where there are sections of the penal code. Sex work in and of itself is not illegal in Kenya, but provisions within the provisions within our bylaws, which are in the penal code, is what criminalizes acts of sex workers. So therefore, living off the earnings of sex work is illegal. That basically criminalizes everyone else rather than myself as a sex worker. Criminalizes even my child. Criminalizes even the partners of a sex worker. It criminalizes individuals who are a support system of a sex worker. That isn't an ideal society where everyone else fits in, because everyone else has a social system that they work in. So should a sex worker decide to seek the services of a bouncer, the bouncer is guilty of a crime, because he's then living off the earnings of the sex worker. So not the sex worker is criminalized, but everyone else around her is criminalized, which leaves the sex worker more vulnerable to violence, HIV infection and transmission, and other social injustices. The Kenya Sex Workers Alliance have successfully conducted research and have successfully done consultations within the sex worker communities and broader other stakeholders to try and look at what are the avenues and what are the procedures under which law reform would happen, and to actually amend some of the laws. They've done research on strategic litigation and are actually collecting data and information from both the wider community and from the sex workers community on a public litigation case that should be rolled out quite soon. They have also gone a step further and trained around 20 sex workers across the country who then act as paralegals. The paralegals are sex workers who then would reach out and their contacts are shared with the community of sex workers, so that the community have trusted individuals who they would reach out to then get information around their legal rights. And they can also call upon when they are being arrested, when they are being violated, and they are able to provide the services to the communities directly. In addition to that, they have also gone a step further to try and have sensitization workshops with the media. We understand the media always carries the story of the day, and the perceptions of sex workers and the narratives of sex workers are told by the media. And so to break that stereotype, they have been able to work with media to change the narrative of how sex worker stories are being told, and tell a different story and tell it from the eye of the sex worker, so that we are able to shift attitudes around stigma and discrimination against sex workers, and even have a more broader topic and conversation around, sex worker issues, sex worker rights, and even trying to challenge the laws around sex work. Very briefly, which I will let Collie talk about, is on the South Africa case, and she will give us a better insight on that, and you will hear from her because that's the most ideal case. I just wanted to say that even on a global level, we have the Global Sex Worker Alliance that is looking towards forming an all-feminist, inclusive alliance that will challenge trafficking and will challenge exploitation. And the alliance does include GATW and Amnesty International, who both have positions on sex work that are supportive of sex work and does not support the abolitionists and the right-wing feminists that are against sex work. Koli.
See the meeting. I don't have a voice. Good afternoon. The minute I'm being told about the time, I become nervous. Because I'm talkative. But not because I want to. It's because of the situation that sex workers in countries they're facing, including South Africa. All right, a lot has been said by Doti. So I'll try just to highlight the South African perspective. As a founding member of Usisonke South African sex worker movement, the largest sex worker movement in South Africa, which was formed in 2003, we are 14 years and 7 months, if I'm not mistaken, and life has not been easy, believe me. The reason we decided to form the movement was due to some of the challenges that my colleague has addressed: human rights violation, injustice, lack of access to healthy facilities, and legal facilities for sex workers. So we decided then, let's form a movement and have a voice. The formation of a sex work-led movement in South Africa through the support of SWET, Sex Worker Education and Advocacy Task Force. The background, Sisonke and SWET being a mother and a child, SWET has been there. And I'm not sure what it would be, the lives of sex workers, if SWET was not there. So thank you to SWET. Credit has to be given. I think it's important. And also get to know, being linked and get to know NSWP, the Network of Sex Work Project globally, and the African Sex Worker Alliance. Doti has mentioned that it has 34 members. We are part of that. So that has also created an opportunities for us to be visible in such spaces. I also believe that credit has to be given. So we as sex workers in South Africa, I think we are so lucky to be part of SWET. They've opened doors for us and decided to invite sex workers in all the spaces, level of meetings, workshops and dialogues in all platforms actually, and respecting the slogan that is part of the theme today, nothing about us without us. Because SWET felt that they don't want to speak on behalf of sex workers, but they wanted sex workers to come and speak for themselves. You see how motivated you are, empowered today, standing in front of you and telling you about our stories and issues and the challenges that we are facing. And also giving recommendations of what are the things that needs to be done in order for sex workers' life to be better. When it comes to challenging policies and labor in South Africa and advancing the HIV and human rights, it hasn't been easy, as I said earlier on. It has been very challenging. As Lynette had said earlier on, that justice system in South Africa, perspective in other countries I know, it has failed the marginalized and vulnerable population. So we work very closely with SWET, because I'm sure you are aware that in countries it's not easy to access policymakers and government and parliamentarians. It has been a challenge. You will ask for a meeting for 7 months, and the day you get an opportunity to only be 20 minutes time that you are given. which is the challenges that we're facing and things that needs to be addressed. 20 minutes is not enough. So through SWET, we work with the advocacy department, which the office, it's called the war room because they make things happen. So SWET has been a mother to us, especially in South Africa, in making sure that in all spaces and on all platforms, sex workers' voices are heard and included. We are also part of the ASICHI, which is the coalition that comprises 72 organizations that are calling for the decriminalisation of sex work in South Africa. Within the coalition, it's advocates, researchers, lawyers, sex workers themselves, experts, and many more, and individuals that are advocating for the health and human rights of sex workers to be recognized and heard. So I'll touch base on the SALAC report, the South African Law Reform Commission. We as an organization, by the way, we recently registered as of May 2017, on the 11th, we now recognize as legal entity. That is good news. So, working with SWET and other partners and allies, we've approached the South African Law Reform to review the law because the criminalization, current law that is in South Africa, the buyer, so, sex work was criminalized in 1957 and then the buyer was criminalized in 2007. So, parties and SWET, they decided to approach South African Law Reform to review the law on sex work. It took, I think, a plus minus 16 years to 17 years to change the laws. See, 1 minute, it kills me. But let me try to wrap up. But I think it's important that I give you a brief on the SALAC report. So the report was then reported on the 26th of May 2017 in Pretoria, which recommended current criminalization or partial. The third option was diversion program. That means we're not okay here. So we rejected that report because we realize that it doesn't make sense to call for the current law and the partial criminalization because the sex workers will still be more marginalized, and in order for them to arrest the sex workers, the clients, they will have to target sex workers. And a diversion program is not actually the option because we don't need to be rescued, but all we're asking for is the human rights of sex workers to be recognized. So we are still in that process. We're also working with Section 27 because now we're in the process of being supported by Section 27 to take the South African case of sex workers to court. That should be shared, I think, in some years. But if you're following SWET and Facebook page and ours, I'm sure you'll be able to get to see what is happening around that case. It's still in the process, but I can't dwell on much because we're still in the process of looking at what are the disadvantages and advantages. The importance of formation of sex worker movement in countries, I think it's important because if sex workers-led movement in countries, they are not formed and supported, they cannot have a voice. So in that way, sex workers become more marginalized, live in fear, they live in dark places, they can't even access healthy facilities, they can't even report the cases that they are facing. One thing that I think I'm wanting to highlight that it is important in terms of, just one thing, in terms of challenging policies and labor framework in advancing the HIV and human rights. As of the 2011, Sisonke, in partnering with SWET, we were recognized by the South African AIDS National Council as a sector within the 18th sector. Through that platform, the sex workers sit on the provincial AIDS councils structures, whereby the issues of sex workers has been addressed. We also sit in the CCM and the Oversight Committee. We are part of those. We're also part of the advisory committee in some of the organizations, which those are things that are needed because sex workers' voice, inclusive of sex workers' voice is important. And through that part of being a sector, we are supported as a sector we're supported capacity building. That's how we became to registered. And then we launched the HIV plan for sex workers with the South African AIDS National Council, which those results of inclusive of sex workers, which we expect the same with the policymakers around legal issues and the laws. I'm sure there will be an achievement around that if sex workers are very inclusive, because all the issues that have been addressed and criminalizing activities that are associating within sex work, we believe that if sex work were to be decriminalized in our countries, we would be able to better our situation.
Thank you very much, Coley. Sorry to cut you.
I'll get you.
I know.
So thank you so much for making time to come and listen to our issues. We've got a lot to share, by the way, but every time, time is just limited, but it's okay. It is okay.
Yes, I'm sure people can come after the session. Thank you very, very, very much, and sorry to interrupt. But we do have one last speaker, and that is Felicia Brown-Acton from New Zealand, who's a champion for the rights of sexual minority groups within the Pacific.
Thank you, Judy and Monica, and thank you to my fellow panelists for leaving me with very limited time. I think it's important that when we're in these forums that shared dialogue and collaboration is done respectfully. So I just wanted to get that point across. To bring the energy back in the room, can I get 1 clap? 2 claps? 3 claps? Thank you very much for that little simple act of solidarity for trans rights. Thank you very much. The Asia-Pacific region is home to 60% of the world's population, roughly 4.5 billion persons, and at a conservative prevalence of 0.3%, it is home to an estimated 135 million persons who may be trans. According to the recent data, there are 5.1 million people living with HIV in the Asia and Pacific region, and 270,000 new HIV infections per year. India accounts for 30% of that, China 22%, and Indonesia 18%. While new infections dropped in India, Indonesia, Myanmar, Thailand, and Vietnam between 2010 to 2016, they jumped 39% in Pakistan and 141% in the Philippines. Transgender women are one of the most vulnerable populations in this evolving epidemic. With a global HIV prevalence of 19% and a risk of HIV infection 49 times that compared to the general population, often being lumped into the category of MSM. There is no data on the HIV incidence amongst trans men. This invisibility and the disregard of our identity and dignity is evident in the insulting and inaccurate data and carries over into most of the areas of trans work. Trans organisations across the world are extremely under-resourced, and the work that is being done by our communities fighting against discrimination and violence day in and day out, but are severely under-resourced. In 2016, the American Jewish World Service, along with Global Action for Trans Equality and Austria Lesbian Foundation for Justice, surveyed more than 450 trans groups. It was found that trans groups in Asia Pacific, like groups from across the world, are doing critical work with little or no resources. More than half of the groups from Asia Pacific are operating on a budget of less than $10,000 a year, and 17% have no operating budget. Among trans organisations, the budget does not include key capacity training that many funders identify as requirements to obtain programming. This has significant implications for not only the groups and the communities they are serving, but the trans movement as a whole. It is unsustainable for a movement addressing the human rights challenges faced by trans people to rely on volunteers and limited staff. When asked what their greatest needs for training and capacity building were, the top responses were support for how to find and respond to funding opportunities, and for healing, anti-trauma work, or burnout prevention. In order to understand more about the priorities for further resources amongst trans groups, we asked what activity groups would do if they had more resources. The most commonly reported areas in need of resources were training for healthcare providers and about trans issues and providing legal services. Next was job training and improved national policies. Other areas where a large number of trans organisations reported needing resources include trans-specific healthcare, general healthcare, and capacity building. In a health assessment, the 12 countries in Asia, hormones were available in 11 countries. Gender-affirming healthcare was accessible in 7 of the 12 countries, but only regulated in 4. Gender-affirming surgery was only available in 4 of the 12 countries, and of the 9 countries that did include transgender populations in national HIV strategies, they were only included under MSM activities. The priorities that we as trans and gender diverse movement continue to advocate for are repeatedly not recognised and not taken up by those in charge of HIV and health programming. The complex interplay of trans identities, stigma, legal recognition, lack of access to education, employment and health increases, vulnerability to HIV, and needs a complex response. Our community understands the structural and institutional barriers that prevent us from accessing critical services. Our priorities are, in fact, a bundled response, which integrates services that recognise the trans identity, bring into the continuum of prevention, care, and treatment while addressing inequality and access. When transgender people seek HIV testing or even basic health services, they confront a health system that doesn't have a place for them as themselves. It is difficult to find gender-affirming providers, and many trans people have negative experiences with healthcare providers. Transgender people are often better informed about the services that they need than are their healthcare providers, who may treat them as objects of curiosity rather than as paying clients. They are then forced to get health information through their own networks. Data shows that the compounded mechanisms of poverty, discrimination, and the environment has yielded overall greater health disparities for transgender individuals. The compounded effects of the societal environmental mechanisms that transgender individuals experience regularly due to transphobia amplify the negative health outcomes. First and foremost, we need support that acknowledges the structural and institutional barriers that oppress our communities. When we talk about gaps in data, we want to address the diverse needs and identities of our communities to create more comprehensive and inclusive data. It is impossible for data on these key populations to truly represent our experiences and stories without our meaningful leadership in every step of the process. Key populations must be included as the experts in identifying the complex social structures in our communities. The reduction of stigma discrimination is critical to achieving better health outcomes and livelihoods of our communities. It is essential that there is a dedicated effort to address the legal and structural barriers, including criminalisation of trans people, legal gender recognition barriers, and addressing intersectionality within our own movement. We all have a critical role in shaping our future, and I want to acknowledge the efforts of trans communities who are working tirelessly to ensure that our voices are heard. I want to acknowledge trans people living with HIV who are critical in decision-making and the HIV and the HIV/AIDS global response at all levels. And I reiterate, nothing about us without us. Thank you.